Yes, ma'am.
Yes.
Good evening to
We
all.
can start.
This is our TNFOG's Bodhana class for PGs. This is our 5th class. Now we have today's topic is infertility. For this, we have Dr. Sanjeevi Reddy sir, Professor of Reproductive Medicine as the external, and internal being Dr. Shanti Rani and Dr. Thangamani from Theni, and the student of Dr. Bharati. I welcome Dr. Anjalakshi Madam for the welcome address. Anjalakshi Madam.
Good evening to everyone. Today's class, as Sambat said, is on infertility. And first of all, I welcome all the students for this Bodhana program. So all of you know it is a subspecialty, well developed. And it is very important as far as your clinical examination, theory examination, and also for your practice. And this is actually a vast subject, but you will have the nutshell of what to be done and what are the things you have to investigate, how to treat and all from the experts. Actually, you present your case and you can clarify all your doubts. For that, we have the teachers, Dr. Sanjeevi Reddy, a renowned teacher who is in receipt of the Dr. B.C. Roy Award. And he is the one who has established the reproductive medicine department at Ramachandra Medical College, first of its in Tamil Nadu. And he is a very good teacher. And we have the other teachers, Dr. Thangamani and Dr. Shanti Rani. So I welcome all the teachers. I welcome all the students. They can have the interaction now. Please start.
Madam Kalpana will coordinate and put the CV. Dr. Kalpana.
Okay.
Yes, madam. Good evening, everyone. I welcome you all for this 6th Bodhana PG training program, which is a great initiative by Sampath madam and Anjalakshi madam and their team. We have an interesting case today on infertility, which will be presented by our Theni Medical College PG, final year PG. We have internals, Shanti Rani madam, who is an associate professor, Theni, president talks. She had done UG Tirunelveli and MD in Madurai Medical College, founder treasurer of Theni OG Society. She was a secretary, Theni OG Society for the past 6 years, and she has organized many workshops and has been awarded a Doctor of 2013 by IMA Theni. She has published many papers in national and international journal. Welcome you, ma'am. Our next external is Thangamani madam. Priya, can I have, yes. Madam is the professor in Madurai Rajaji Medical College, published many articles and research papers in national and international journals. Madam has got 29 years of experience in government service, and she was a recipient of Best Doctor Award from District Collector.
Kalpana, only one correction. Thangamani madam is also. Kalpana, Thangamani madam is also an internal teacher. One teacher, Reddy sir. Yes. Proceed.
Yes, ma'am. Even though she's now at Madurai, she has been attached to Theni for a long time, and she has got a great affection towards Theni. So I think she has been selected for that as an internal for Theni students, I think. We have our external learned expert, Sanjeevi Reddy sir, who is a professor of reproductive medicine and surgery, Ramachandra Medical College. And he has got 31 years of experience in the field of obs-gyn and reproductive medicine and surgery. He was a former HOD, Department of OG, SRMC, now HOD of. The one thing I want to tell is, sir is a BC Roy awardee, a prestigious award, received his award in 2015, and he has started MCH in Sri Ramachandra Medical College. Sir will be, and I welcome you, sir. I also welcome the student, the presenter, who is final year PG in Delhi Medical College, Dr. Bharati, who is going to present on infertility. Over to you, Dr. Bharati. Dr. Bharati?
Yes, ma'am. Yes, ma'am. Started.
You can start sharing your slide.
Good evening, ma'am. I kindly thank my HOD ma'am and all my chief for me this opportunity. Today I'm going to speak on infertility. A 26-year-old female, Mrs. Sindhu Priya, who is a housewife belonging to socio-economic class 5, living with her husband, came with anxious to conceive for past 4 years. History of presenting illness. The couple presented with complaints of inability to conceive for past 4 years in spite of regular unprotected sexual intercourse. No history of previous evaluation and treatment for the same. No history of excessive weight gain. No history of excessive facial hair or body hair growth. No history of abdominal discharge PV. No history of lower abdominal pain or backache. No history of burning micturition. No history of intermenstrual or postcoital bleeding. No history of chronic cough, weight loss, or evening rise of temperature. No history of decreased sex drive. No history of nipple discharge. No history of cold intolerance, constipation. No history of heavy menstrual bleeding. Going to menstrual history, time menarche at 13 years. She has a regular menstrual cycle, 28 to 30 day cycle, lasting for 3 days. Moderate flow, not associated with pain, not associated with clots. And her last menstrual period is 23/12/2021. Marital history, marriage in 4 years, non-consanguineous marriage, living with her husband, no history of contraception. Andrological history for the male partner, age of the husband 32 years, who's a former by occupation, no history of trauma, no history of any previous surgeries, no history of undescended testes, no history of smoking, alcohol or drug abuse, no history of mumps in childhood, no history of polyuria, polydipsia, no history of sexual dysfunction, no history of multiple sexual partners. The coital history, frequency of intercourse 5 times per week, couples aware of ovulation and fertile period, intercourse is complete, no history of vaginismus, dyspareunia, no history of any surgery in vagina, no history suggestive of retrograde ejaculation, no history of washing genitalia with water or cream after intercourse. Coming to past history, no history suggestive of PID or endometriosis, no history of tuberculosis, no history suggestive of STD, no history of galactoria, no history of previous surgeries, and no history of diabetes mellitus, hypothyroid or hyperthyroid. Personal history, a patient is on mixed diet, normal bladder and bowel habits, no history of smoking, no history of alcohol or drug abuse, no history of multiple sexual partners. Coming to general examination, the patient is moderately built and nourished, height 152 centimeter, weight 66 kg, and her BMI is 28.5. She's afebrile, no pallor, no icterus, no pedal edema, no lymphadenopathies, no goiter, no hirsutism, no acne, no acanthosis nigricans, breast development normal, no evidence of galactoria. And secondary sexual characters, pubic hair and axillary hair plus. And vitals are stable, pulse rate 88 per minute, BP 120/80 millimeter per mercury. Systemic examination, CVS S1, S2 here, R is normal vesicular blood sound here. Coming to examination, inspection, abdominal examination, no visible mass, no distension, no enlarged veins, no surgical scars. Palpation, no abdomen soft, not tender, no organomegaly, no mass, no free fluid. External genitalia, pubic hair plus, no anomaly, no local lesion, no discharge, no cyst, hymen not intact. Speculum examination, cervix and vagina healthy, no vaginal septum, no discharge. Bimanual pelvic examination, uterus normal size, anteverted, mobile, non-tender, fornix free, no adnexal mass. Coming to summary, Mrs. Sindhu Priya, a 26-year-old female, married for 4 years, living with her husband, came with inability to conceive for past 4 years, a case of primary infertility for evaluation.
Okay. At the outset, I would like to thank the TNFOG team headed by Professor Anjalakshi and Secretary Dr. Sampath Kumari and Coordinator Dr. Kalpana for this novel idea of starting Bodhana. See, if you want to develop anything, any country or anybody, so education is important. All other associations, they are giving so much importance for conducting CME for the already doing practice other people. These people, they have taken up this novel idea. First, they want to educate the PGs and update them with knowledge so that whatever they are planning, they can bring out in the future also. I congratulate them for this novel idea. So Dr. Shantirani Madam, other people, just you can ask the questions. After that, I will start. In the history, whatever changes you want, you can ask. Then I will go for the relevant things.
Bharati, this patient married for 4 years,
Yes, ma'am.
living with her husband.
Yes, ma'am.
And whether any past history of any treatment, whether any medical, any consultation, she is aware of this fertile period or something, whether she is knowledgeable, she had approached any previous treatment, any history you are having?
No,
Because she
ma'am.
has been married for 4 years, you are telling.
Yes, ma'am. But she has not taken any proper consultation outside, ma'am. First time she is visiting.
Are they
our
knowledgeable of the fertile period?
Yes, ma'am. She's knowledgeable of the fertile period, ma'am.
All
If
the
she
other
has not
history, I think-
taken treatment from other doctors, how she knows about
Fertile
fertile
period.
period? Is she educated? Or she is a Google doctor?
village health nurse, toys, local people. So she has not taken any treatment. She has not consulted for this anywhere.
Yes, ma'am.
She
And
told that,
apart from
Shantirani,
that-
she told.
Yeah, apart from that, I think she has covered all the other things.
Okay, next slide.
Yes, sir.
Okay, here one is, since she's married, whether they're staying together or not important. Next is you have written regular coitus. Here also you
Yeah.
have to ask the patient whether they're practicing vaginal coitus or not. That is important. Next is whether they're using any lubricants. That is also is important. This also can interfere with her. Okay, other things are. One more thing is here you have written everywhere no, 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 like that. Is it necessary to go for all negative histories here? That is for MBBS students is okay. For you, it is necessary. Okay, next slide, please. Okay.
Yes, sir.
How many no's you put? Huh? The very first class I told. Thank you.
Okay.
Actually, some
next.
amount of repetition is there.
Hmm.
Okay, next. Okay, next. Here also, when you are presenting the female history, no need for us to go into so much depth of the male partner. Just
Okay,
you can find out whether he had 3 things were important in these things. One is age of the thing. Next is occupation, because this can affect the thing. Next, whether he's having any coital problem. That is the second thing. Third one is whether he was investigated or semen analysis done or not. That is important.
Yes, sir.
Okay. Next. Okay, next. Okay, next. Okay. Anything significant here?
Yes, sir. BMI. obesity.
Alone is high. Okay.
Yes, yes, sir.
Okay, next. Okay. Okay, next. Okay.
Here, is there any necessity to tell no vaginal septum?
Vaginal septum is not needed. Yeah.
Not necessary. See, if
Okay,
it is there, you mention.
Normally, is there, you have to mention, otherwise there is no need to it.
Also about this hymen, madam. Hymen.
The hymen, she had written hymen.
No need to mention about the hormonal.
Yes.
Money not, it's not necessary.
Yes, ma'am.
Okay, next. So this is as though you are expecting everywhere, like the madam was asking, no, there is septum you are expecting in every patient. Same way, like no adnexal mass you are expecting for everybody. That should not come, no, just whatever
Yes.
findings, no. See what what are things you will check when you are doing bimanual examination. First, when you insert the fingers, you will feel the cervix. So whether the size of the cervix is normal, then you are going to move and see whether there is any tenderness is there or not. Then if there is nothing is there, then you are going to put the other hand, then you are seeing the size of the uterus, whether it is uterus is antiverted, retroverted size, whether it is mobile or not. Then you will go on this palpate fornices, whether there is any tenderness is there, then any adnexa is palpable or not. If it is usually we won't palpable, but in thin patients, there is a chance that sometimes we can palpate ovaries, otherwise
Ovaries.
usually you won't palpate. There is any enlargement is there, then you have to mention about then whether it's cystic, solid, whether that is mobile, all the things. Otherwise, you should not mention any negative points. Okay,
Okay, okay, sir.
then next. Okay, next. That's all now.
Yes, sir. That's all.
Can you stop your sharing for some time? Then I will go for. See, your history also, my first history also is almost same, except little difference. BMI alone is there is some difference is there. So we'll go systematically. Just,
Okay, sir.
so same thing, only 4 years and 3 years different. That's the only thing. She's getting regular periods. Her LMP is 24th, and she's getting her sexual history also is normal, and menstrual history is normal. Examination also is normal. BMI is only 23. That is normal. So, what is your impression here?
Sir, a case of primary infertility, sir.
Okay. Can you define what is primary infertility? First, you tell me what is infertility.
Sir, inability of a couple to conceive even after a regular unprotected sexual intercourse, sir.
Period you have to mention.
For a period of 1 year in a woman less than 35 years of age.
Okay.
And
So
after
there are two things. One is like, suppose if the patient is less than 35 years, we'll wait up to 12 months. Suppose if it is more than 35 years, if it is 6 months itself is enough. If the patient age is more than 40 years, we won't wait 1 year, 6 months also. Immediately also you have to check the patient. If it is, everything is normal, then you can ask them to stay together. Otherwise, you may have to go for the investigations. Then you are telling about the primary infertility, no? Can you define what is the difference between primary and secondary thing?
primary infertility is defined as inability of a couple to conceive even after 1 year of unprotected sexual intercourse who had no prior conception.
Yes.
In secondary infertility, who had prior conception, it may even a live birth or stillbirth, maybe an abortion or a ectopic.
Okay. She had conceived once, after that she didn't conceive. That I think it might have ended up anyway. maybe normal delivery or miscarriage or ectopic, anything hydroid-formal anything, then we will go as second. So now you know, like this patient has come to you with this history, you know that examination finding also. How will you proceed next in this patient?
First, we have to counsel. I will counsel both the couples. What is the first counseling has to be given both the partners, sir.
For what you will give counsel? We don't know, like that patient has come, she is anxious to become pregnant. So you took history and you examined. We don't know the
Sir,
diagnosis.
Then
No.
I will proceed with basic blood investigation, sir.
Why? See, why
The
you want to
female
go for the blood investigations? What you will get? Nothing, no?
Yes, sir.
What you will do? Any patient comes to you.
Yes, sir.
Okay. Here, see, there are three things is important. Any infertility. First patient has come to you. You have to do the transvaginal scan in all patients.
Okay, sir.
So by manual examination itself, you won't get anything. So if you do the ultrasound exam, can you tell me what are the findings you can expect from doing transvaginal scan?
Sir, we can study the ovarian status, sir.
Not only ovary, uterus.
Tell all the findings, ma. What all?
Ovaries. No. Uterus, what are things you can get?
Any uterine anomalies? Any
Okay.
adnexal masses?
No, one you finish up, then you won't miss. If you go finish one is anomaly, next you go to ovary, next to tube, no, you will miss anything. Uterus means you finish up uterus. Myometrium, endometrium also you can get something, findings. No.
Okay. Sir.
Same way, what are things you will get from the myometrium? You can see abnormality. One you told like that anomalies.
Anomalies, sir.
Huh.
Then
Anything else in the myometrium?
uterine fibroids.
Okay, anything else?
Then that's also.
Hey,
Any polyps? Any polyps, sir?
No, that will go for the endometrium, madam.
Endometrial
Myometrium.
polyps.
myometrium.
Myometrium you told fibroids. Anything else? One more thing is important.
Bodhana, you can answer.
So any other PG also can answer, no problem.
Any endometrial polyps?
No,
That is
he is
endometrium,
asking
I'm
about
telling, no.
myometrium.
Myometrium.
What is the other condition? Common is fibroid. Another condition?
That box they mentioned adenomyosis, Asherman syndrome.
Yes,
uterine-
adenomyosis, no.
Yes,
That is
sir.
also, see, myometrium is over. Endometrium, you are telling, no, polyp.
Yes, sir.
Anything else? So it may be mucosal polyp or endometrial polyp. Anything else?
University has mentioned as endometrial polyp.
Anything else we can make out? In the endometrial problems you can get. What is that called? Intrauterine additions. Can you get?
Asherman syndrome.
Can you make out by ultrasound, transvaginal ultrasound?
No, sir. We can
You cannot make out. Okay. Okay. So many things. So what are the things? Adnexa, what are the things you are telling about the ovary? What are the findings you can get from ultrasound?
Any ovarian cyst, chocolate cyst,
Whether ovary is
PCOS.
normal or abnormal. Okay. Size of the ovary, that volume of the ovary,
Yes, sir.
how many antral follicles are there? That is important. No.
More than yes, sir.
One you are telling, no. Next is PCOS also, no.
Yes, sir.
That also you can make out. Not only the peripherally situated follicles, the cortex also will be more here. Okay. Next you are telling tests like some cyst. It
Yes.
may be functional cyst, ovarian cyst, or endometrial cyst also you can make out. Tube, anything you can make diagnosed by ultrasound?
Yes, sir. Hydrosalpinx.
Hmm.
TB
Okay.
salpinx.
Okay, that also, and relation of the ovary, whether it is mobile, that cyst or something also is there, whether that ovary is adherent or not. Sliding side, have you heard?
Sir.
Sliding sign.
Sliding signs.
Mobility of the ovaries. Okay, don't bother. That also you can make out whether there is any additions are there, whether it is adherent to the posterior surface of the uterus, everything. So then 3 things are important in infertility. Any patient comes to you. One is whether the patient is ovulated or not, ovulating or not. For that, you know, like that she is getting regular periods, no?
Yes, sir.
So that means 95% of patients, if the patient is getting regular periods, then we can imagine that patient is ovulating. Okay. Some 5%, even the patient is getting periods regularly, she may not be ovulating. Another thing is you told here the male factor, the semen analysis is normal. No,
Yes, sir.
we have seen here. This is the semen analysis. It is normal. Okay.
Yes, sir.
So like here, she is getting regular periods and these 2 things are over. Third one is important. What are the important third one? For any infertility patient, if you want to start treatment, these 3 things you should know. So this is the one.
Plus,
Tubal factor also should be excluded. If this 3 is normal, then we will go for the treatment. Tell me, what are the tests available to exclude the tubal factor?
so for tubal patency, we can do histosalpingogram,
Good. Anything else?
saline infusion sonography.
Okay.
Then other for tubes, fallopian tubes, falloposcopy available.
That's all
The
very
commonest
high
we are
tech.
doing.
That's all very high
Then
tech.
his laparoscopy, sir.
Okay.
Diagnostic
So
histolaparoscopy.
these are the simple things what we will be doing routinely. Other things all it won't be advisable for you people. So saline infusion sonography, HSG, diagnosis histolaparoscopy. No, these are things. First, which one you will advise for this patient?
Sir, histosalpingography.
Okay, good. So sometimes we have to go directly. We have to go for the histolaparoscopy instead of going for the HSG. You will get many things, but saline son also, if you are good, if you are able to do like that, you will get maximum information with the saline infusion sonography also we can do. Or sometimes this histolaparoscopy, even though this is invasive test, cost will be more. In all places it may not be available. Sometimes we have to go for directly histolaparoscopy instead of going for the HSG. Can you tell me the indications when you will go for the histolaparoscopy directly?
Histolaparoscopy is both diagnostic and therapeutic. When there is any tubal blockages and any other adhesions are there, we can directly go for histolaparoscopy.
I told you directly you are going without doing HSG, other things. No.
Yes, sir.
With the history, taking history and clinical examination itself, you will decide we will go for the laparoscopy, histolaparoscopy instead of going for the HSG.
Yes. So any other tubal factors, TB, salpingitis, Asher?
Okay. You are telling about the tubal block like that, which is showing bilateral corneal block or failed IUI. How many IUIs usually you will be doing in a patient advice before taking up for a IVF?
We can advise 3 cycles of IUIs.
Okay, 3 or 4 maximum.
Okay, sir.
So why you will no? Why not go for 6, 9, 12 like that? Why you want to stop with 3 itself?
Sir, stress, it's more, it causes more stress to the patient also, sir. First reason.
IVF also is more stressful, is not that much. Okay, these are the things. So like, okay, previous failed IUI, prolonged marital life, more than 5 years, or if the clinically when your exam history or clinical examination suspected of endometriosis, then also better to go for like that. Unexplained infertility, have done all the things, patient is not conceiving. Patients more than 35 years also, it is better to go for the histolaparoscopy instead of, or the patient was treated outside. many cycles of ovulation, induction, all the things, if she has come to you, better to go for it. Or previously she had some surgeries, then you are suspecting. And also like ultrasound is suggested of something like polyp, other things all like that, you will be going like that. So, okay, here, something here. Okay, this your patient, we have done the HSG. This is a picture. Can you tell now?
Yes, sir. Bilateral coronal block.
Coronal block. What is these things?
Hey,
There is spill is there, no? Uterus you can
sir.
see, everything is there, everything. Here also tube also we can see, no? See here, there is spill is there both sides. It is a normal study, no?
Okay, sir.
So what is your diagnosis? History, everything is normal. So seminal is normal. She is getting regular periods. Now HSG you have done, the tubes also is normal.
Normal
So
intestine.
what is your
Sir,
diagnosis?
It's a case of unexplained infertility, sir.
Very good. Okay. Can you define unexplained infertility?
Unexplained infertility, infertility in the couple, in the no obvious male and female factors, which contributes to 10 to 20% of infertility cases.
No, I told you, no, we should have three things. No, one is patient should be ovulating, the tubes should be normal, the seminals also is normal. If she is not conceiving for 12 months, so we'll call it as unexplained infertility. Okay. So what is your plan in this patient? So your patient is unexplained infertility. What is your, how you are going to manage this patient now?
Sir, first I'll do a diagnostic histoolaparoscopy. Then
now only you have done, no, just like that you have done the HSG, both tubes are patent.
sir.
So your diagnosis now unexplained
Ovulation
infertility.
index. Sir,
Okay.
ovulation induction along with IUI.
Ovulation induction, good. Can you define what is ovulation induction?
Sir, supplementation of fertility medication for inducing ovulation.
Tell.
In an anovulatory or the oligoanovulatory women, a supplementation of fertility medication for stimulating the follicles. Sir.
Okay, there is some confusion on this induction and stimulation. There are two things are there. So ovulation induction means the patient is anovulatory. Then you are giving some medication to induce ovulation. Ovulation stimulation means already patient is ovulating. There you want more than one follicle, then we'll call it as ovulation stimulation. And one more terminology also is there. This is controlled ovarian stimulation or controlled ovarian hyperstimulation. Can you tell anything? If you know, you tell like that, otherwise I will explain.
In assisted reproductive techniques, control ovarian hyperstimulation is done. Before ovarian induction, that pituitary downregulation is done with the GnRH analogs.
Now here we want multiple follicles. So already ovulating, we want multiple follicles, ovarian follicles, then we'll call it a controlled ovarian hyperstimulation. Hyperstimulation, ovarian stimulation is more than 1, 2 to 3 like that. Here we will be getting more than that. Okay. You are telling about here we are going to for ovulation induction plus IUI, ovulation stimulation plus IUI, no?
Yes, sir.
And can you define what is this intrauterine insemination?
Selection of a healthy donor sperm and introducing it to the uterine cavity.
Why you want to go for donor? Here seminal
Same, sorry, sir.
normal, no?
Sorry, sir.
So IUI may be a husband or donor. No, here we won't go for the donor. It is only husband we are going to take. So it is involves the preparation of the semen and placing the sperm inside a woman's uterus to facilitate fertilization. No,
Yes,
so nearer thing. What is this goal? of IUI?
So to
The goal is to increase the number of sperm that reach the fallopian tubes and subsequently increase the chance of fertilization. See, with ovarian stimulation, we are, even if the patient is ovulating, more than one follicle you are going to get, 2 or 3 maximum. And also after preparation, we are taking good sperm, that is motile sperms, and keeping nearer the cornua, so that all motile sperms will reach the tube earlier. That way there is chances there more chance for to become pregnant. What are the indications for IUI?
unexplained infertility.
Your colleague also can answer, no problem. Okay.
So unexplained infertility. First.
Okay.
Then male factors. In male factor infertility also we can go for IUI.
Okay. So male factor, that is borderline thing is there, unexplained infertility. Next is cervical problem, no?
Yes, sir.
Cervical scar tissue, previously you have done, no, that cervical
surgery.
mucus, it may not be properly thing. There you will be going for the thing. Or if the husband is having ejaculated dysfunction, then also it is advisable to go for the intrauterine insemination. So then you are telling about the ovulation induction, no?
Yes, sir.
What are the drugs you can use for the ovulation induction?
Clomiphene citrate, letrozole, GnRH analogs, and GnRH antagonists also can be used, sir.
Why you will go for the analogs all like that for induction of ovulation for thing? Now leave off the IVF.
Yes, sir.
Will you use like that?
Yes, sir.
Can you go for better classification like that? Oral ovulogens and injectables, oral drugs and injectable drugs. That is a better, no?
Okay, sir.
For you. So oral drugs, so clomiphene citrate is the commonly used drugs. Nowadays, they allowed the letrozole also.
Yes.
And sometimes combination of these drugs or other things like metformin and steroids like prednisolone, other things, or the patient is having associated problems like hyperprolactinemia, there also will be using all these things. Suppose the patient is not responding to these things, then we may go for the, sometimes go for the parenteral drugs also, no, like HMG, urinary or recombinant. Okay, you told no clomiphene citrate you will be using. Can you tell when you will start the drug, which day of the period?
From day 2 to day 5, sir. We have to start
Okay.
from day 5.
Okay, day 2 to day 5 you can start. Okay, how many days you will give usually, normally? There are so many ways, things is available like that, no? The dosage, other things are like that. That you go, normally how many days you will prescribe?
So for 5 days.
Okay. How much dose you will start? Usually the starting dose.
Starting with 50 mg to 150 mg clomiphene citrate.
Okay. In any other condition, you will start less than 50 milligrams.
For challenge.
Ovary is highly sensitive. Tell.
Ovarian.
No, usual dosage is 50 milligrams.
Yes,
sometimes we may have to start less also, 25 milligrams also. Can you think? PCOS, what is the problem?
Hyperresponder.
Sir, come get.
PCOS.
Yes, sir.
There, what will happen if you give any inducing drugs?
Sir, if more than 20 follicles.
Then I'm not asking you definition, I will ask you later. So you will have many follicles can develop, no?
Yes, sir.
So there you have to start the less. So there you can start only 25 milligrams also. Can you tell me what are the common complications of clomiphene citrate?
Sir, multiple pregnancy,
Okay.
then ovarian hyperstimulation syndrome, sir.
So one is cyst formation. There is no evidence of increased malignancy. One more complication, when it develops, then you should not give this drug again in her lifetime. Can you tell what is that problem?
Ovarian.
Ovarian carcinoma, I told you, no, patient is not just only the mentions like that. This drug won't produce. In fact, any other drug also like that, until now it is not proved that will increase malignancy. Okay.
Okay, sir.
Any other complication? Rarely these people will develop visual disturbances. So that one, if they develop, you should not again give them. Some reports are there, permanent blindness also they can develop. Any patient
sir.
develops, you should not. And there are two definitions you should know, like clomiphene failure and clomiphene resistance. No? Do you know what is failure and what is resistance?
Sir, after 3 cycles of maximum dose, no response has been documented. It is defined as chromate failure, sir.
Okay, maximum dose. How much maximum dose you will give?
150 mg, sir.
What will happen more than that?
Sir, ovarian hyperstimulation can occur, sir.
When you will go for more dose, no, like 200, 250, patient is not responding, then only you will go for that one, no?
Yes, sir.
But here patient is not responding, then only you are increasing. She is not going to develop any OHS here, no?
Yes, sir.
What is the side effect of clomiphene citrate? Why even like many patients are ovulating, the pregnancy rate will be very less. What is the reason?
Sir, it is anti-estrogenic. Sometimes it can also cause.
Okay, anti-estrogenic effect at the level of cervix and also endometrium. That's why it is not advisable to give more than 150. Even though some books mention they can give up to 250 milligrams, even the patient ovulates, patient is not going to become pregnant. That's why the FDA is advised only up to 150 milligrams maximum. So what is clomiphene resistance?
So non-responders.
Okay, same way you told, no, like the maximum dose. So if even if the patient is not ovulating with the maximum dose, that is 150 milligrams, then we'll call it as clomiphene resistance. Okay, so like, how will you manage this patient? Or just before going to that one, can you tell me how many percentage of patients will ovulate with 50 milligrams, with 100 milligrams? You told maximum is 150 milligrams. With 50 milligrams, how many percent of patients will ovulate? With 100 milligrams, how many percent of patients will ovulate? And 150 milligrams, with how many percent of patients will ovulate?
So, about 60%.
Dr. Bharati, your friends can also answer.
Okay. First,
Okay, you see like that around 50% of patients will ovulate with 50 milligrams, 100 milligrams around 70, and 150 milligrams almost 85% of patients will ovulate. Other than 15 to 20% only clomiphene failure, okay, resistance. So how will you manage clomiphene resistance patients or failure patients?
Sir, we have to switch over to other drugs available for ovulation induction.
What other drugs?
Sir, letrozole.
Okay. How much you will give?
Letrozole we can give 2.5 to 5 mg, sir.
Maximum dose?
Maximum 10 mg.
1.5.
Okay, up to 7.5. This is a normal dose. Then other things are there. So another thing is metformin also. Suppose if you are not used like that, if you add to the clomifene citrate, so there is many patients will ovulate. There is a, particularly in PCOS patients, they will respond. Can I tell me the dose of the metformin, how much you can give maximum?
500 mg to 750 mg TDS if the patient is tolerating well.
Have you seen the 750 milligrams tablet?
Sir,
500 milligrams to 750, yeah.
yes, sir.
750, is it available?
No, sir, no, it's not available.
Then what is the dose next to 500?
1 gram.
Navya has written 500 milligram TDS.
Okay.
Next
So
you have is the
750
850 milligram.
850 milligrams. So that's why like you can give
Okay, sir.
maximum 2250 like that. Usual dose is we will be giving for our Indian patient, they will be able to tolerate up to 1500 milligrams. So what is the side effect of metformin?
Sir, it can cause first main cause of side effect is gastritis, and it rarely causes lactic acidosis.
Okay. So that's why how will you start like that to if you give to any patient, how you will know whether this patient is going to tolerate or not? So how will what advice you will give to the patient? How you will start the medication?
First, I'll start with 500 mg BD for 10 days. If she's tolerating well, we can change it to 500 mg TDS. Sir.
No, just start this one in the night after food. So for 1 week, then you increase to BD, then 3 times day after food only. So you should be very careful when the patient is having any kidney function. No, there it is not advisable to give. Okay. So other drugs available is the gonadotropins, and so these are things already we told you. Next is drilling. So what are the side effects of gonadotropins? Why we should not just like that go for the gonadotropins? What are the side effects of gonadotropins?
Sir, in gonadotropins also it can cause ovarian hyperstimulation syndrome. Sir.
Okay, one is the cost factor we need to monitor here. No, so multiple pregnancy, one is the problem. No, how much is the multiple pregnancy rate in oral ovulations, and what is the incidence of multiple pregnancy in gonadotropins?
Sir,
okay, go back and read like that. No, it is not that much easy. One is hyperstimulation. Also, you are telling always hyperstimulation like that. No. So how much percentage you can get in oral ovulations? How much? What is the percentage of incidence of hyperstimulation in gonadotropins?
30% with gonadotropins, sir.
What is 30%?
30% more incidence of ovarian hyperstimulation syndrome.
30% is very high, you won't get. Even an IVF patient, 30% you won't get. Okay, multiple pregnancy, you can say. Oral ovulations, it will be around 10%, less than 10, 8 to 10%. This will be around 30%. So that will be very less hyperstimulation. Okay. What is this ovarian drilling commonly misused procedure?
Sir, for PCOS, the best we can do for ovarian drilling, sir.
Any indication is there particular patient will get benefited, or all patients we can do?
Sir, non-responses to metformin for 3 months.
We have gonadotropins available, no? In spite of letrozole or clomifene citrate with combination with metformin, we get tried, patient not ovulated, then we have gonadotropins are available. Okay, read the drilling also. That's also important for you.
Okay, sir.
So indications you should know when you have to do like that. So then we'll go for the second scenario. Same thing here only. All other
One
things.
minute. One student has asked a role of estrogen with CC for ovulation induction. One of the student has asked in the chat box, sir.
Role of estrogen.
Estrogen with CC.
That is for this synchronicity between the endometrium and this
No. Some
ovarian
student has
follicle.
asked, so I asked that.
Okay, for induction of
No.
ovulation, there is no role for estrogens at all, unless there is some endometrial thickness is very thin, other things. So like this is just like what we'll be giving now, testosterone or something, or if you use estrogen also, it can suppress. So rebound phenomena can, in this we never use for any ovulation stimulation or ovulation induction.
The other question is, how does steroid help in induction?
So there will be like, it will suppress in PCOS patient or adrenal origin also, that
Yes, sir.
tell madam.
So can we make it out by clinical examination?
Which one, madam?
That hyperandrogenism.
Clinical also we can make out. That's not like, see there it's.
They want to know by adding steroid, which are the conditions they can add steroid to counteract the adrenal hyperandrogenism.
One is like anything, if they estimated the serum testosterone levels, if it is high, we have to find out whether it is of ovarian origin or adrenal origin. For that, we have to estimate the DHEAs. If the DHEAs is elevated, then it is of adrenal origin. If it is normal, then it is ovarian origin. In that conditions, you can supplement the steroids. Dexamethasone 0.5 milligram. There are various doses are there from 6th day to 12th day or 14th day. Just give. Or some people will supplement from day 2 also throughout the month. Other things. So it decreases the levels of this androgens. Then patient can become pregnant.
Dr. Reddy, ask them again about the clomiphene resistant and failure. I think the girl did not have a clear idea. What is the resistance, clomiphene resistance? What is clomiphene failure?
Okay, the patient has ovulated for 3 to 4 cycles, but she did not conceive. Then we'll call it as failure. Patient is in spite of maximum dose of
did not ovulate.
Clomiphene resistance.
Thank you. Thank you.
Okay. Here in this patient, here only her periods are 45 to 60 days once, and the rest all same only. Only BMI is 29. And clinical examination also, bimanual examination, everything is normal. What is your diagnosis, Bharati?
Sir, PCOS, sir.
Okay. Can you define PCOS? How will you?
Sir, it is a state of hyperandrogenism accompanied by
Can you tell the Rotterdam criteria to diagnose PCOS? See, the endocrinologist will say always hyperandrogenism. As a gynecologist, you won't say hyperandrogenism. That is the least for us.
Yes, sir. Oligoanovulation or anovulation, hyperandrogenism, and polycystic ovaries characterized by 12 or more follicles, each of 2 to 9 mm in diameter.
You need to have present all the 3, or 3 criteria should be there, or 1 is enough, 2 is
At
enough?
least two of the 3 criteria must be enough for a diagnosis of PCOS, sir.
You have seen no PCOS patient, or the patient, every patient is having hyperandrogenism?
No, sir, not all patients are having.
Okay, that's why first you should not come. First, every patient will be, most of the patients will be having like that. You can say 95% of patients will be having, they are having anovulation or oligo-ovulation. Okay,
Yes.
irregular thing. Next is, it may be clinical or biochemical hyperandrogenism. If you do the ultrasound examination, there will be polycystic morphology. Okay, this then you will call it as PCOS patient. So almost already we have discussed like that. How will you manage a patient with PCOS? We have discussed until now the unexplained infertility. No?
Yes, sir.
Here, what extra management you will do?
Lifestyle modification.
Good.
After weight reduction of the patient.
Okay.
Then we can start the patient
What
on
is
insulin.
lifestyle modification? You write in the prescription like that, you change your lifestyle, means she will ask you like that, what is that lifestyle modification? You just tell me like that. Shall I change my dress? Like that she will ask.
Weight reduction, sir. Weight reduction and dietary modifications.
That is different. Lifestyle modifications. Weight reduction is important. I'm not
Yes, sir.
telling, I'm not denying. There are, how will you reduce what advice you will give to reduce the weight?
So daily brisk walking of at least half an hour.
Two things in that. One is diet control. Second is the exercise. In these two ways, we can reduce the weight. Okay.
Yes, sir.
What is this lifestyle modification? In the lifestyle modification, one of the
Adequate
things,
to reduce
controlling the weight,
stress.
no, controlling the weight or reducing the weight. What are the other things?
So in the modern
Suppose if
stress.
she is smoking. Okay, stress also is important. So if she is, her job is stressful, you advise her to change that one to some other less stressful job. Okay. Suppose occupation is there, that is affecting like that. No, that's also you have to change. Suppose she is a smoker, you ask her to change that, stop. Suppose she is taking liquors or she is taking some drugs, this all she has to stop. Okay. And what type of thing? Suppose she is having only sedentary life, then you can advise her, even if she is not obese also, by changing like that type of things, it can improve. These are the things you have to tell. Lifestyle modification means not reducing the weight alone. Okay. So this can be like, next is ovulation induction and IVF, you told, no? Last option is IVF is available. So here, ovulation induction, unexplained infertility, you told first clomiphene citrate. Suppose if it is a case of PCOS, which is the drug of choice for ovulation induction?
Letrozole. Metformin. Before that, we have to start metformin, sir.
For all patients? Okay. This is also, there is controversy is there. Whenever the patient is having impaired glucose there, then only they will advise to start. That's the one debate. But some people will start for this one. It is corrects the metabolic corrections it will do, even if the glucose intolerance is there or not. That's the one thing. So next. So this also is controversial, debatable like that, whether to clomiphene citrate is really not good for PCOS patient. Letrozole is so good like that. Many papers, it is telling like that, both are equal. Some patients who are not responding to clomiphene citrate there, if you use like that, some patients will respond. But recent papers, some of the papers has come up, the pregnancy rate is better with letrozole. But whatever is there, we also did study, it is not showing that much. We don't know whether the medical company people did this thing or really that is good that much. We don't know like. So everybody can do their own experience, use their own experience. You can start for some patient clomiphene citrate, for some patient letrozole, then you can take your decision which one is good. Just by reading one paper, two people paper, you should not take decisions. That is good. So there are so many things. IVF is there. Finally, we'll discuss about the IVF. What are the indications? Okay.
Okay, sir.
So this is the other thing. The HSG. First, you were telling, no, there is bilateral corneal block. You told, no.
Yes, sir.
You tell me about this sex. Is there any difference between this HSG and that is HSG?
Yes, sir.
Okay,
Tubes are not.
Okay, what is your diagnosis?
Sir, this is bilateral corneal.
Bilateral?
Corneal block.
Very good. How will you proceed next?
Sir, we can go for a proximal cannulation.
Don't you confirm whether it is really corneal block or not? What is the false positive rate?
But I'm not sure about the rate. But many times due to spasms, proximal block can occur.
Okay, up to 33%, almost more than 30% of patient HSG is false positive. It will give some abnormality saying like this, the tubes. So all these patients, any tubal problem, if you found by HSG, so we have to subject this patient for histolaparoscopy, whether it is really the there is blockage there or not. It is false positive. Suppose if the histolaparoscopy, the tubes external normal, so there is histoscopy also normal, then you are telling something, no? Proximal tubal
Cannulation.
Okay, very good. Then we can do the same setting. When you are taking the consent, you can tell this also like that. We'll go for the
Yes.
proximal tubal cannulation also you can take. So this patients, okay. Tell me like that. You are telling about the proximal tubal cannulation, no?
Yes.
So how you will do like that? There are so many ways are there to do. Which one you will do as a gynecologist?
Sir, ultrasound. Sir, method only. Sir,
Methods.
sir ultrasound guided tubal cannulation.
When you're doing histolaparoscopy, why you want to go for the ultrasound then? Okay. So mostly histoscopic cannulation you can go. Even fluoroscopic guided also some people can go. That's all radiologist will be doing. We as a gynecologist, we have to go. What is the success rate?
Sir, after this procedure, 80%.
So 60 to 90% of patients will be able to do cannulation. Suppose if it is failed, then you have to go for the IVF. Okay. What is the pregnancy rate?
I'm not sure.
Okay, 30%. Again, after 6 months, 1 year, 2 years, like that, again it will be reclosure will occur. Okay.
Yes, sir.
Okay. That's the another thing is this is the next X-ray. That same patient we have done this thing, various scenarios.
Tubes are not visualized.
Not visualized. Huh? It is there up to here. It is seen here also seen partially up to here. Can you see?
This distal block of.
Part of the tube is here, no? Proximal.
Yes, sir.
tube.
Distal block.
So somewhere it is in the middle of the tube, no?
Okay, sir.
Okay, how will you manage this patient? So this patient also you have to subject the per histolaparoscopy, all these patients. One is there may be leak when they are injecting dye or they have not properly or the radiographer not exposed on time. Suppose if it is because it is only water soluble, if you wait for some time that will get absorbed, and the person who is injecting also may not, if she stops injecting and if wait for some time, that dye will get absorbed, then you won't see the thing. No, and also even if there is it is patent tubes, that tube will dye will spill through the fibril end and that will go up diluted there. It will get absorbed, so you won't see. That's the problems you can face. So how will you manage? Suppose it is a real case of mid-tubal block or mid-tubal problem, what you will do?
So we have to confirm the diagnosis, sir.
That I told you, no, we have done the hysterolaparoscopy.
Then we
There
can
also
go for procedures. We can go for procedures and re-anastomosis of the tube. Excision and re-anastomosis.
okay. You are telling, no, like salpingoscopy, other thing, no. Here only that is useful. But usually if there is a mid-tubal block is there, that is not going to be successful.
Yes.
Okay, this patients we have to go for the IVF only.
Mm.
If it is proximal or distal, we can do something. Otherwise, in the mid-tubal thing, not advised. We don't know where is the block, whether it is single, multiple blocks, all the things are there. So that's one. Not only that one, the tubal mucosa also will be damaged. Then we will have problems. So the false positive is telling, no, it is up to 30%.
Yes.
So like here if you take, see here, it is up to femoral end. After that, there is no spill is there. So this type of things, which is going to be distal block, then how can you manage?
So distal block can be of a femoral block or any hydrosulfings like that things. For if in any case of femoral block, we can do fimbrioplasty, sir.
Okay. So there is additions are there, salpingolysis or salpingostomy also we can do. So the pregnancy rate is also up to 60%. Ectopic, any surgery on the tube we have to keep in mind, and counseling also when talking to the patient. Ectopic pregnancy, already there is some tubal disease is there. Whatever you do like that, there is chances there. Here 5%, and if it is going to be like salpingotomy there, so the pregnancy rate will be very less, and also the ectopic pregnancy also will be increased. Next is here, suppose tubocarnal anastomosis. Previously, we are doing for the carnal block. No, if it is not successful, or previously when the IVF was not well developed, that time we are going for the carnotubal anastomosis. The pregnancy rate also is very less. The ectopic pregnancy rate also will be more. This is for recanalization. No, many patients will be coming nowadays. The pregnancy rate will be very good in these things, up to 80%. That's one thing. And ectopic pregnancy is around 7%. So this is the thing. Okay. The other thing you are telling something about the tube, hydrosalpinx, no?
Yes, sir.
So like how will you manage this patient?
Sir,
HSG, you have done the HSG, it is showing like this.
Sir, in hydrosulfings, the ovulation induction and other will be almost 50% failure, sir. So we should go for IVF. After excision of hydrosulfings, we should go for IVF.
Any patient comes to you with hydrosulfing just like that, he will, what procedure he will do?
Sir.
You told excision, huh?
Yes, sir.
Is there any place for corrective surgery?
No, sir.
Is there any grading of the tubal disease?
No idea.
Okay. So we have to subject these patients for histolaparoscopy.
Okay, sir.
So the tubal disease, there are three things. If it is mild, there is a chance is there, we can allow her for correcting surgery. We are telling that fimbriolisis, other things you can do. Here only the salpingoscopy, other things will tell us to see the mucosa, how it is like that, how much it is damaged, depending on that. If it is going to be grade 2 or grade 3, better to go for the IVF. And also like when you are going for the thing, IVF also, there are two ways. One is you are telling salpingectomy. That is what the people were saying. And after that, the people were telling like that, even if you block the carnal end by clipping or disconnecting, then the pregnancy rate will be higher. Because if there is hydrosalpinx is there, if you transfer the embryos, because of the fluid intermittently will be released into the uterine cavity, that is toxic. So it interferes with this also. And one more thing is the inflammatory cytokines will be released from these tubes. So that can also affect the implantation. That's why even if you disconnect or clip the tubes, if the fluid is staying, that inflammatory cytokines can affect. And many infertile patients, if you say, I will remove the tube, nobody will accept. And another complication, what they have told is, if you do the salpingectomy, it can interfere, like for the ovaries, there will be two blood supply. One is from the ovarian artery, another one from the uterine artery also. No? When there is damage, when you are removing this one, so from this uterine artery, the whatever is coming, that blood supply can be affected. Some reports has come up, the ovarian reserve has decreased. That's why we should be very careful nowadays when you are doing the salpingectomy. Instead of that one, the third option available is just clip the tube, but at the same time, the fluid should not be collected in the tube. That's why you do the linear salpingostomy. So open complete the tube. So the fluid won't be collecting there. There is nothing will be there to observe, and the cytokines won't be affecting the implantation. That's what we are practicing. So the other HSG is showing like this.
Incomplete.
What is this one?
Sir, adhesions, intrauterine adhesions.
Okay. How will you manage? What are the reasons for this?
Any previous curatages or any previous
Okay.
recurrent
That's why
abort?
if any patient with infertility goes to any person, no, just like that they will be doing the DNC. That's why it is not advisable. Or suppose she had previously some miscarriage or something, it can happen. What is the commonest cause in India for this one?
Sir,
One more important cause in India. Yes.
Tuberculosis.
Yes, genital tuberculosis. So how will you manage this one? How will you confirm this one, and how will you manage?
So confirmatory histosalpingography, we can manage by
That is not
hysteroscopic removal.
confirmation. No, that's what you have done here. It is not confirmatory.
Sir, using a transvaginal ultrasound.
You told you cannot diagnose at all this intrauterine adhesions by transvaginal scan.
Yes.
Then you are telling now that is confirmatory. Now, if you put some little saline inside the cavity, you can make out there also. The gold standard is the hysteroscopy. Okay, you can see like this. So how will you manage?
Sir, a hysteroscopic removal of adhesions, sir.
Resection of these adhesions. Okay. So then we can go forward. Okay, here also there is, this is the classification. You can see mild, moderate, severe, depending on that. So like there is a chance there, mild and moderate, sometimes there is a chance that she can become. If it is severe like that, it is very unlikely we have to advise a surrogate. Okay, that's one thing. So another thing you told, no, we can diagnose by
uterine anomaly.
Yes. What is this?
So bicoordinate uterus.
How will you confirm? This is HSG is showing there are two horns. I will say this is only septate uterus. How will you confirm?
Hysteroscopic visualization.
Hysteroscopy you cannot know, no, whether bicoordinate uterus, septate uterus also, it looks same only when you go for the hysteroscopy.
MRI.
I think your college is very rich. No? It is available in your college MRI? Huh?
Yes, sir.
So we should not waste the resources.
Okay.
Here, see, we should not just like that send our patient to somebody else. We should diagnose on our own. So anything in our hands are available like that to diagnose at our level. Whoever is prompting there, no, they can tell directly, no problem. You have heard 3D ultrasound, will it help?
Yes, sir.
Can you tell this one? Same thing subjected for 3D ultrasound. Tell me now, it is bicarnate uterus or septate uterus? Okay,
The
3D
two cavities are there. And
okay, two, like you can make out by 3D ultrasound, we can get more than 95%. We can diagnose whether it is septate uterus or bicarnate uterus. You see, this all myometry is present here now. It is there. There it will be absent here in bicarnate uterus. The gold standard is always histolaparoscopy. Hysteroscopy alone won't give you. So if you do the laparoscopy also, we can see the two horns separately there. Suppose if it is septate uterus, the fundus will be like wide. There may be little dimple will be there. Otherwise, it may not be there anything. That's the only thing you can make out. In bicarnate uterus, two horns will be separate. Okay, that we can make out. So hysteroscopy, you will see that depression below septum also it looks like that. And in bicarnate also it looks same. There are two cavities will be there that hysteroscopy can enter into that one. Okay, aorta will be open there. So how will you manage this one? So this is the hysteroscopy also we have done. It is like this. So can you say this one by seeing this one whether it is septate or bicarnate is very difficult. That's why you have to do the laparoscopy also to say it is definitely only. So that function is done by 3D ultrasound. Okay. When you will go for the MRI, rarely sometimes this is also like there is additions are there. You are not able to make out there only you can the uterus is some deviated or something. That time if you subject the patient for MRI, then you can get. Rarely you will get subject the patient. Routinely we won't be doing. Okay. How will you manage this patient?
Resection of septate.
Okay. What problems it produces if there is septum is there?
Recurrent abortions.
Okay.
Recurrent miscarriages.
Usually, even though some patient it can affect the conception, mainly it is miscarriages. They will say in the septum, the vascularity will be very less. If the embryo get implanted there, it won't get that much vascularity. That's why the miscarriage rate will be very high. Okay,
Yes, sir.
that's one thing. Okay, we have done the laparoscopy. The findings are like this. What is it?
Sir, endometriotic changes.
Okay, so it can present. There are so many ways of presentation. Just like this, these black spots and orange spots or white spots, or sometimes there may be defect in the peritoneum itself. No, it will be additions. All those things will be there. Okay, this way also it can come. Or sometimes, can I tell the classification of endometriosis?
Sir, mild, moderate, severe, mild with the superficial additions, no ovarian involvement. And moderate, there will be flimsy additions with ovarian involvement. In severe, there will be a dense adhesion and when both ovaries are involved.
What is the cause for infertility in endometriosis? So this
So
is
mainly it causes tubal
stage
kinking and anatomical distortion of the tubes.
Okay.
So
Suppose there
it
is
may cause endometriotic chocolate cyst in the ovaries.
See, you told like that there is distortion of the tubes and additions, everything, it can interfere. For the deep endometriosis or ovarian endometriosis, there won't be any additions at all. There also patient won't become pregnant. That means some other fact is, what are the reasons, what are the causes for the infertility in endometriosis? Can you tell? One you told that is correct only. The tubal additions, everything distorted anatomy also can interfere, or ovarian additions, everything can affect. What are the other factors?
Chocolate cyst of the ovaries.
So what will happen there? See, other ovary is normal. No, suppose single ovary, it is containing like 3 centimeters, 2 centimeters endometrial cyst present. That is not going to create so much problem, no? So ovarian reserve can still present there. Follicles can produce. So these are the reasons mentioned. So increase peritoneal macrophages, that increase phagocytosis of the sperm, decrease sperm binding to the zona pellucida, proliferation of peritoneal lipocytes, and also increase cytokine levels. Here also I was telling you that inflammatory cytokines, that also will interfere with the implantation, increase immunoglobulin production, embryotoxic in the serum, defective natural killer activity. These are the things, that's the problem. We told there are 4 stages: minimal, mild, moderate, and severe. You are telling our stage 1, stage 2, stage 3, stage 4. So just tell me the gross management. A patient with endometriosis, she has come to you with infertility. So just tell me like that. If stage 1 is, stage 2 is there, what advice you will give? Stage 3, stage 4, what you will do? There will be always exceptions will be there. That you leave it to the specialist. At your level, what you will advise?
Sir, even minimal endometriosis causes unexplained infertility, sir. So in endometriosis, we can directly go for, we can try IUI, and if it is failed, we can go for a
Laparoscopy.
Okay. So in reproductive medicine, only 2 treatments. One is IUI, another one is IVF. 2 things only is available. No. So we want to know when to use which one. No. I cannot say like for all patients I will do of IVF. No. In endometriosis, when you will advise IUI, when you will advise IVF? Tell me. Okay, simple. See, stage 1 and stage 2 ovulation induction IUI. Okay, there will be exceptions will be there. I didn't want to confuse you. So stage 3, stage 4 IVF. Okay, just keep like this. This is enough for you. Okay, you're telling about ovarian endometriosis. So the scan is showing like this. How will you manage this one?
Sir, filled with the chocolate.
No, I'm not asking like that. How you will diagnose like that? You have diagnosed it as ovarian endometriosis, that endometriotic cyst. How will you infertility? Your patient, you have done the scan. Now one side ovary is showing like this. How you are going to manage this?
Can laugh.
Okay, if it is going
We can,
to be...
I can go for a excision of the chocolate cyst.
Okay. So what precautions you will take before? Is there any size limit above which you will go for the surgery?
More than 5 centimeters.
Why is big? No. Okay, 3 or 4 centimeters. More than that, they will advise surgery. That is okay.
Okay, sir.
Age also is important. Patient should be young. And what is the other important thing you will see? Ovarian reserve is important. Suppose already decreased ovarian reserve is there. What is the disadvantage of doing excision of that cyst?
Sir, advanced maternal age decreased ovarian reserve.
No, here, if you do that excision of ovarian capsule, no, it further decreases the ovarian reserve. Along with the cyst excision, there will be some normal amount of the ovarian follicles also will come up. So that's why always you have to do the AMH before doing the cystectomy. After doing, after 1.5 to 2 months, again you have to estimate, then we'll know how much it has decreased. Not necessarily for every patient we will do the surgery. So if you think that the patient needs IVF, directly no need for us to do this one at all, do the cystectomy, directly you can go for the IVF. Unless if you are suspecting there is malignancy, or if you think when you are going for the transvaginal retrieval of the oocytes, it is going to interfere with, then only you have to interfere with the endometriotic cyst, otherwise not necessary to interfere. Okay. In younger patients, the ovarian reserve is good, then you can go for the cystectomy. Okay.
Yes, sir.
And you can go for the, after that, removing that one, go for the ovulation induction IA for 3 cycles. If she is not conceiving, then you go for the IVF. So this is the way we have to go for this thing. Then you are telling about, no, when you are doing ultrasound. So this is the, this way it is their picture.
Sir,
Anjalakshmi madam, it is 7 o'clock. You want to stop or we can continue?
Sir, you can continue, sir. You can continue.
Okay. Thank you. Tell Bharati.
sir, it's an endometrial polyp.
Okay, there is hypoecheic area is there in the endometrial cavity, most probably like polyp. How will you confirm?
Sir, confirmatory ultrasonogram. Sir.
This is ultrasound only, no?
Yes, sir.
How else you will confirm?
Hysteroscopy.
Okay, that is gold standard. You are partially correct that ultrasound also, if you put little saline, no? Saline hysterography.
Saline.
Then you can get that one clearly. And gold standard is, so this is the saline hysterography. So you can make out the polyp.
Dr. Navya has written in the chat box, sir, saline infusion sonograph.
Okay. Okay. Gold standard is hysteroscopy. You can make out. How will you manage this one?
Sir, you can hysteroscopic removal of the polyp.
Okay. So like all polyps you have to remove. Sometimes we will be facing when you take up the patient for IVF. Before that, we cannot make out any patient by ultrasound. If you make out, you have to remove the polyp. Then start the stimulation, other things. Sometimes what will happen, it may not be that much visible before starting stimulation, but after stimulation, we will get the polyp. We can identify after 3 days, 4 days. Usually for 5 days, we'll be giving the gonadotropin. 6th day, we'll do the scan. That time, you can make out the polyp. So what to do? Is there any size of the follicle will affect the thing, or any polyp can affect, or smaller polyps you can don't bother, we can proceed with the treatment?
Sir, size of the polyps matters, sir. But any polyp, you should go for removal, sir.
Yes, if the polyp is there, better if you remove, if you exclude all other factors, better to remove this one, no? And there are some papers or studies showed if the polyp size is more than 1.5 centimeters, it can interfere with implantation. If it is less than that, it may not interfere with the things. But in unexplained other patients, better to remove. So this is the next thing.
Yes, sir.
What is this? Can you tell?
Sir, it is in submucous.
How many fibroids are there?
Multiple fibroids.
Where is the one? Where is the uterine cavity? cervix, they have written already. It is easy for, where is the cervical canal, endometrium, where is the fibroid, and all these things. So this is also important, not
This is
only knowing.
Submucosal polyp.
So the fibroids, one is our important thing is relation of this fibroid to the where it is situated.
Yes, sir.
The classification of fibroids.
So one is submucosal fibroids.
Okay, submucous, intramural, and
Submucous
subserous. No, that is
Yes.
grossly. And depending upon how much, whether it is pedunculated, submucous, and other things, the classification is there. I don't know whether you have seen or not. If you are able to see that, you can read. I didn't want to confuse you more. Okay, just tell me traditional teaching, whether the fibroids will affect fertility and which type of fibroids you will advise to remove and
Sir.
which fibroids you won't bother and you start treatment directly.
So submucosal and corneal fibroid interfere with the conception, sir. The subserosal fibroid doesn't much interfere with conception. So for submucosal
Intramural fibroid,
no, sir. Intramural fibroid also won't interfere with conception.
it won't affect.
Yes, sir.
Okay. Okay, that is the traditional teaching. Whatever size it may be in the submucous fibroid, remove. Subserosal fibroids, usually it won't affect. Intramural fibroids, individualize. So that is what that thinks. But many patients with fibroids can become spontaneous, also they will conceive. When you're doing cesarean section, many times you will come across fibroids. But thing is, there are some, nowadays, many papers are coming, many studies they have done. So there are things that non-distorting cavities also. Whenever there is distortion of the cavities there, it can interfere with implantation. But they have taken the fibroids alone, in the intramural fibroids, without distorting the cavity. They have subjected one group and they removed the fibroids. Other group, it is not distorting. They proceeded directly with the IVF. Here, first group, they removed the fibroid, then they went for the IVF. The pregnancy rate, whenever there is fibroids are there, the pregnancy rate will be less when compared with non-fibroid patients. Here, when they did remove the fibroids, the pregnancy rate is equal to those patients without fibroids. So whenever there is fibroid is there, then the pregnancy rate will be very less. And that second group, after that, again, they subject this patient for myomectomy, and then they subjected this patient for second time for IVF. The pregnancy rates has become normal, like any non-fibroid patients, so like that. So the concept, new thing is, the cytokines released from the fibroids also can interfere with the implantation. That's why when you're going for the IVF, better to remove the intramural fibroids also, then you can go like that. That's the one thing. So other thing is, what are the indications for ART? Now you know, no, all the things we have covered. So like unexplained infertility,
failed IUI,
failed IUI,
male infertility factors,
PCOS patients, male we have discussed,
male infertility factors,
fibroids we have discussed, endometriosis we have discussed, not in depth, still we have discussed. Now, can you tell me what are the indications finally we have available with the ART? Can you tell me what are the indications to go for the ART?
Sir, abnormal fallopian tubes, bilateral corneal block.
So this is the first indication, no? Bilateral tubal block is the indication for IVF. For that one they started. Now there is so much liberalization is available. Tell, one is you told tubal thing, then we discussed already previously also.
Failed IUI.
Okay, failed 3 IUs or whatever is the failed IUI. Okay, triple disease, failed IUI. Anything else?
Male factor infertility.
Okay.
Then unexplained infertility.
Endometriosis also we discussed. No, stage 3, stage
Endometriosis.
4. Unexplained also we have done the IUI, failed IUI. There only we are going for the ovulatory dysfunction. In spite of ovulation, it's not like that. Unexplained also like that. What is this?
PG.
Suppose some anomalies are there. You are thinking chromosomal anomalies. You want to exclude that one. No, hereditary disorders. So we want to subject the embryo for biopsy. So there also no other factor also. Here we will do the IVF, then go for the embryo biopsy, exclude that one, take the good embryos, then also an indication. Fertility preservation. No?
Yes, sir.
Cancer is there. There also we have to subject the patient for stimulation, retrieve the oocytes and freeze it. Then you can start the chemotherapy, radiotherapy, other thing. Then you can plan for the transfer. Okay. So here, whenever there is decreased ovarian reserve or like premature ovarian failure, all these things also, then you have to go for only egg donation or embryo donation. Okay. These are the things. Finally, we discuss intrauterine additions. Grade 3, there is very less chance endometrium completed destroyed, or you have tried the laparoscopic resection, again is forming recurrent additions, or you tried to transfer previously not failing, not successful. There also you have to go for the things surrogacy. Okay,
Yes.
These are the things. So if you have any other doubts, I'm ready to clarify.
Any students can post the doubts in the chat box. Bharti, உனக்கு டவுட்டே இல்லையா?
No, ma'am.
Full infertility chapter sir has covered.
Yes, ma'am. Sir, thank you, sir. Thank you very much, sir.
Thank you, madam. You read well.
Yes,
You
sir.
did well.
Like that students have read very well, sir. Teni Medical College.
Thank you, madam. In spite
Thank
of COVID, we have seen 600, more than 600 cases of COVID in our hospital, sir. These people are working for that. In spite of that, they are putting a lot of hard work to study.
But the doubt in the chat box, what she has mentioned. Rotterdam criteria says biochemical or clinical evidence of hyperandrogenism. For biochemical evidence of hyperandrogenism, which investigation we should use? Pre-testosterone or total testosterone?
So actually pre-testosterone is the best thing, but the estimation of the test, what we are doing is not that much correct. That's why we'll be doing the total testosterone, then SHBG, then you can calculate the pre-androgen index. So that will give us correct, clear picture. Suppose we can do the testosterone that is raised because the serum albumin will decrease in case of PCOS patient. That's why even though the testosterone levels is normal, the pre-testosterone will be increased. That's why estimation of the pre-testosterone is always better.
Sir, one more, Dr. Navya has asked, womb sperm and donor sperm, elaborate indications. Anything?
Always, if there is sperm is available from the husband, we'll take the only husband like that. Rarely, suppose if there is non-obstructive azoospermia, there is no sperm in spite of micro-TZ, then we have to go for donor sperm. Or some patients, they say like economically we cannot offer for the IVF, so we won't mind going like that. That's the one thing they can go for the donor sperm. Or if the chromosomal anomaly is there in those patients, that is recurrent is coming, there also we have to go for the donor sperm. These things mainly.
Another only one question, sir. Which semen analysis, if fructose is absent, what does it mean? Already she asked the question, same question.
See, one is if the fructose will be produced from the seminal vesicles, there is seminal vesicle agenesis, or there is a block is there beyond seminal vesicle. That is exactly that block is there the fructose will be absent. The volume also will be very less, and there will be azoospermia will be there. We have to subject this patient for transrectal ultrasound, then we will know whether there is any dilatation of the vas is there, whether seminal vesicles is present or not. Depending on that, then we have to decide what type of treatment we have to go for.
Yes, sir. Does increased liquefaction time in semen analysis significant?
Yes. Usually it will be less than 30 minutes. That is normal. Occasionally there will be increased viscosity, other things. It takes longer time. So that is abnormal. So like whenever there is longer time is there is problem is there is various methods that particularly for preparation everything we can prepare it different methods by using this one. So that is different things.
Yes, sir. That's all. What are all the predictors of success in non-obstructive azoospermia? Dr. JM, somebody has asked. People are doing TC even for patients with non-obstructive azoospermia. What are the predictors of success in non-obstructive? This is not needed for PG, I think. Anyway, you can answer.
One is testicular volume is important. Next is there is micro TC. There is we cannot say definitely we can get even FSS is raised up to 40 also 50 also like that. There is up to 40 to 60% recovery chance is there sperms. But it is very difficult to say after subjecting the patient for micro TC, then only we can say whether it is, we can still get the sperms, but it's very less chance. Another thing is if you go for the Y chromosome micro deletions, so if C is available, then there is chances there you can get A and B is not advisable for this patient. They won't get the sperms there.
Thank you very much, sir. Very useful discussions. Everyone has mentioned the same, sir. It was
Thank
really
Thank you, sir.
very, very useful for the PGs.
Thank you, madam.
Thank you,
Thank you
thank
for
you so much.
involving
Thank you,
me in
sir.
this.
Thank you, sir.
Thank
You
you.
covered almost all the subject. Thank you so much for spending your time for our students, sir. Thank you so much.
All students, not your students, all students.
Especially our students, madam.
Around 250 people are there.
Okay, especially.
But
Ma'am, once
entirely
again,
students.
ma'am, once again, I take this occasion to thank your HOD ma'am and chief ma'am and all our assistant professors, ma'am. Thank you for the opportunity, ma'am. Thank you.
Reddy sir, they want to see you again. So
Yeah.
we have after 6 months another one class. Thank you, sir.
Okay,
Thank you so much. Anjalakshmi madam, do you want to tell anything? Tangamani madam, Shanti Rani and Dr. Bharati, thank you for your presence, and Sanjeev Reddy sir has covered everything. Really,
Yes,
it was
madam.
very useful. Thank you, thank you.
Yes,
In
madam.
spite of this, we still have more than 100 participants. Okay, sir. Thank you, sir.
Okay.
Thank you for
Thank
you
madam.
too, madam.
Thank you.
Thank you for
madam.
Anjalakshmi madam, Sambat madam and Kalpana.
Thank
And
you.
sir, special thanks to sir too. Thank you.